To paper 713, large postvoid residual is a strong predictor of the diagnosis of multiple system atrophy in patients with Parkinson's syndrome from Japan, and presenter is Dr. Yamamoto.
Thank you, Chairman. My name is Tatsuya Yamamoto from Japan. So I will talk about the large postvoid residual is a strong predictor of the diagnosis of multiple system atrophy in patients with Parkinsonian syndrome. We have no conflict of interest. So it is difficult to differentiate multiple system atrophy, it is MSA, from Parkinson's disease, at least in the early stage. So urodynamic study is useful in differentiating MSA from PD. However, many UDS parameters are difficult for almost all of the neurologists to understand. So we aim to clarify which UDS parameter was useful in differentiating MSA from PD. So we retrospectively reviewed 273 case records. UDS and external anal sphincter electromyography, we say EAS-EMG, were performed in patients with MSA and PD. So we determined the useful UDS parameter among postvoid residual, detrusor and prevalence of the detrusor activity, and the degree of bladder contraction, which is examined by the Schaeffer's monogram, and the mean duration of motor unit potential in EAS-EMG for differentiation of MSA from PD by multivariate stepwise logistic regression analysis. So this is the result. So mean disease duration of MSA, we usually classify the MSA into MSA-P and MSA-C. MSA-P is a MSA whose dominant clinical phenotype is Parkinsonism, whereas the MSA-C, whose dominant motor dysfunction is cerebral dysfunction. And the mean disease duration of MSA patients was significantly shorter than that of PD. And the mean UPDRS3 score, which assesses motor dysfunction of PD and MSA, and very commonly used in neurology area. So the mean UPDRS3 score for MSA-P patients was significantly higher, that is significantly more severe than for PD patients, suggesting that motor dysfunctions were significantly more severe in MSA patients. So this is the result of the logistic analysis. So I'm sorry, it is a very busy table. So our result is that the postvoid residual larger than 150 millimeter during the free flow study strongly indicated the diagnosis of MSA rather than PD. Odds ratio were 8.7. And PVR during pressure flow study larger than 150 milliliters also indicated the diagnosis of MSA. However, the presence of detrusor activity and neurogenic change, EAS-EMG, we say the neurogenic change, EAS-EMG, when mean duration of motor unit potential was larger than 10 milliseconds, did not significantly contribute to the differentiation of MSA from PD in our study. So my conclusion is that the present study indicated that postvoid residuals larger than 150 milliliters during the free flow study might be more useful than other UDS parameters in clinically differentiating MSA from PD. Thank you for attention.
Thank you. Yes?
Hi, Doug Tincello from the UK. I'm not a neurologist, so I'm probably going to demonstrate my ignorance. You described this as a retrospective study.
Yeah, yes.
So these are all patients who will have had the urodynamics because of urinary symptoms, is that correct?
Yes, almost all patients had urinary symptoms.
Okay, so you're not implying that you should do urodynamics as a diagnostic test for patients with these neurological conditions?
In our university, so urodynamic study is usually used for the diagnosis of Parkinsonism, whether patient has a Parkinson's disease or MSA or other Parkinsonian syndrome. We used urodynamic study for diagnostic test.
Okay. Is there not a neurological test to diagnose Parkinson's disease?
Yes, this is basically not a neurological test. It is not commonly performed in neurologists.
Okay. So would you do a urodynamic test on a patient with a Parkinsonian condition who had no urinary symptoms?
I'm sorry?
If you had a patient with symptoms and signs of Parkinson's disease or multisystem atrophy, but no urinary symptoms, would you do a urodynamic investigation and an EMG?
If patient do not show the urinary symptom, so I think the urodynamic study or EMG is not, in this point, not necessary.
Okay.
Not necessary for all patients.
I have also a comment. For me, you can differentiate between the two conditions because MSC patients are younger. Usually they have early sexual dysfunction, and what's surprising me is what I learned from my neurologist is that you have early denervation sign on the EMG, and on your study you find no change in the EMG study, which are, according to my neurologist, pathognomonic for the condition. So why do you explain that your patient has no denervation sign in the EMG study?
So you mean that why we perform the EMG?
No, my question was, as I know, usually the EMG is pathognomonic for MSI. If you see denervation sign on early denervation sign on EMG, it's a pathognomonic for MSI. But you show us that you saw no difference in the EMG study between the two conditions.
So this is, and purpose of this study is to find which parameter is used for differentiating between PD and MSA. And in this study, we did not simply compare the ESCMG between PD and MSA. So, and in our previous study, we compared the mean duration of ESCMG between PD and MSA, and we found that the patients with MSA had significantly larger duration of multi-unit potential, suggesting that MSA patients may have significantly neurogenic change. So,
Okay. Thank you very much.